Well, good afternoon, everybody. My name's Damon Palmer, and I'm the Policy Lead for Health and Social Care Integration at the Department of Health. And it was interesting listening to some of the feedback from this morning's session about what you've learned. Somebody said the importance of transformational change, and somebody else asked why isn't it happening? And hopefully I will touch on some of those priorities in my presentation this afternoon. So what I plan to do for the next 10 or 15 minutes to set out what is the case for change, and then to set out what we're presently doing within the department to support and enable that to happen, and then finally to give you a taste of the work that we're taking forward and the next steps to support integration, and in particular, what do we mean by integration. So in terms of the case for change, I'm sure you're all aware that we have an ageing demographic society. That's very much a reflection of the advances and the investment in healthcare. So that is something that we can very much celebrate, that people are living longer. But I would argue that perhaps the investment in healthcare services hasn't perhaps reflected the needs of those who actually use the majority of our health and social care. So all of the data tells us that older people, frail older people, and those with long-term conditions use by far the majority of our health and social care services, something like 2/3 of that £120 billion of spend. But as I say, I would argue that perhaps the way that we've invested in hospitals, community services, primary care and social care doesn't reflect the needs of our ageing society. The highest users of health and social care happen to be those with 2 long-term conditions. And the prevalence of multiple conditions, multiple long-term conditions, comorbidities, is increasing over time, as is the prevalence, as I'm sure you're all aware, of dementia. But I would argue that the most important factor is the increasing prevalence of long-term conditions. So there is a very strong link between, as we age, our propensity for a long-term condition and also for multiple long-term conditions, and the way that we configure our services to cater for these needs has to be addressed. So why does it have to be addressed? Well, first of all, patients, service users, carers and families have told us that often those long-term conditions are treated as episodic care, that we don't see the person, the individual, me, you, as a person, but we just see the condition. And this leads to multiple uncoordinated assessments, poor care, delays in provision, duplication, poor patient experience. Patients and users aren't given the information to provide them with the choice or control, the independence. There are multiple trips to see their healthcare providers. There's an increase in emergency readmissions. And there is obviously a safeguarding issue there as well. So that is a very key message that we are picking up about the way that services are delivered. It's not the actual care that people receive from their GP or in the hospital. It's if you need to go from one to another to another to another, perhaps the transition, the flow of information. It's how it's all packaged, tailored, seamless, that is the issue. And so as you heard from Beverly, there is an increasing need for information to be able to follow the patient at both, but also at a strategic level to inform commissioning at a local community level as well. And indeed, there are rising expectations of our NHS services, and so that in itself is a challenge. And unfortunately, there is still, ignorance is a strong word, but understanding of social care. Many people still think that it's part of the NHS and that it will be provided when they retire free of charge, like the NHS is, and perhaps have picked up the recent headlines about Dilnot that in fact they will be required to pay the first £70,000 of their care. And so over the last 10 years, we've seen a 50% increase in emergency readmissions. We've seen an increasing proportion of delayed discharges that are attributable to the NHS. We've seen variable investment in community services, capacity, responsiveness, and productivity. And the main theme that we have picked up time and time again is the lack of joined-up care is the biggest frustration for patients, carers, and users. And in my world, where within integration we use the example of Torbay a lot, this picture down here is Mrs. Smith, where they drew up a notional user. Mrs. Smith is the usual user in Torbay, where lots of people go to retire. And then they started design services around her needs to understand exactly what she needs, and then to start to tailor services so that she needs and gets the services that she requires. So we worked closely with the NHS Future Forum, and we heard that people want to experience coordination. They don't necessarily want organisational restructuring. It's not about restructuring all the processes. People want care. They don't care where it comes from, whether it's health or social care or primary care or the voluntary sector. They just want care. And so integration, integration, integration was the top demand from patients, service users, and carer organisations during the Health and Social Care Act listening out. Apologies for those of you that can't see this from the back, but this is a web of care that was drawn up by National Voices, who are an umbrella group for carers and users of health and social care services. And what it shows is an Alzheimer's patient and their carers' contacts with health and social care services over the last 7 years of their life. And I'm sure you can see that that's quite a web. And through the discussions that I had with them about this web of care, what alarmed me most is what the voluntary sector, the Alzheimer's Society, they felt that they needed to step in and to try to hold that ring together, that they were trying to pull all of the health and social care services together on behalf of that patient, on behalf of their loved ones, in order to try and get the services to work at a very vulnerable time for them. And so I think that's something that is something that we are trying to address, and I'll set that out later. So what is our approach? Well, first of all, within government, we believe that there is now an opportunity for local partners to find local solutions to improve local services. That there is no blueprint for success, there is no silver bullet, and it will depend on local priorities with input from local service users. And we've listened, and we do appreciate and understand that there are national barriers, and that is something that we are committed to addressing. We are trying to create a permissive environment that will enable localities to innovate and to shape services to meet local needs. So for the department, we're going to work through three particular strands of work: a legal framework, the allocation of resources, and holding the system to account. In terms of the legal framework, we believe that we've demonstrated our commitment to integration through the Health and Social Care Act, and we are continuing to reinforce that through the draft Care and Support Bill. In terms of the Health and Social Care Act, I'm sure you've all heard very much about it, but integration is very much like a black pull through a stick of rock through the Health and Social Care Act. It strengthens the duties to promote integration for the Commissioning Board, for clinical commissioning groups, for health and wellbeing boards, and for Monitor. It also promotes the use of pooled budget, joint commissioning, and the draft Care and Support Bill will introduce complementary measures to promote cooperation and integration across the NHS and local government. We are also investing significant funds, up to £7 billion, over this spending review to support investment at the interface between health and social care. So investment in services such as reablement, services such as step up and step down care, hospital avoidance, winter pressures, avoiding emergency admissions, changes to the tariff around readmissions within 30 days, and hospitals taking responsibility for post-discharge as well. So we have invested significant funds into enabling joint working between health and social care. In addition to that, we have, as you heard from Beverly, set out the importance of integration in the mandate to the NHS Commissioning Board, provide clarity on what integration will look like, and in particular in reference to long-term conditions and Domain 2. We are ensuring that the outcomes frameworks across the NHS, adult social care and public health are aligned and reinforced. We are commissioning research around developing an outcome measure of integration, an indicator of a patient's experience across and within the NHS, social care and public health. And we're also involved in there is also a great deal of evidence that we're continuing to build on, such as the work of the 4 community budget sites that are pooling some £40 billion of public services resources to enable greater transformation and reform of public services, as well as work with the personal health budget sites to understand how we can provide person-centred care for individuals. And so finally, the department, alongside our partners Monitor, the Association of Directors of Adult Social Services, the Local Government Association, and the Commissioning Board, have formed a collaborative to integrate, if you like, integration, to take forward our duties and our ambitions around integration. And one of our first products will be what we're calling, and I'm sure the name will change, but a common purpose framework, which we plan to publish in May, which will set out our ambition for how we can promote integration at pace and scale, describe the national programme and the commitments over the next 3 to 5 years that we will hold ourselves to achieve this ambition, to understand and address the barriers and the gaps, both nationally and in our evidence base, describe how we think progress will be measured, and that's it from me. If you have any questions, I'd be happy to take them.
Thank you for, I'm Bill Holt, I'm a local county councillor, North Yorkshire County Council.
Hello.
And I'm on one of the social services committees. Okay. I mean, you've highlighted the issue, but it's the speed of pace of change that the NHS seems to have a problem with, because we do need more integration. And one of the areas that concerns us is the government is heavily pressing on local authorities to produce a system of direct payments where we pay the patient, or sorry, the person we're dealing with, money when they've been assessed, so they find their own care and deal with their own issues. But when we had a meeting with NHS providers, I think it was a PCT, but I think there were clinical commissioning people there as well, and we said, how many of the NHS patients have you got on direct payments? And they said, oh, we're making progress. In the whole of North Yorkshire, we've got 3.
Okay.
And I think there's that mismatch, and until that mismatch is sorted out, we're really not going to get very far with integration, because there's only half the glass, if you like, and really there needs to be a little bit more effort put into that. Also, bearing in mind the PCT is leaving a lovely legacy to the 5-6 clinical commissioning groups in North Yorkshire of a £19 million debt.
Well, yes, as you'll know, in adult social care, the speed and progress and ambition around direct payments and personal budgets has been been very ambitious, and the target for, I think it's this year, was originally set by Paul Burstow as 100%, but I think that's been reduced to 75% or something of that order. But there is work taking place through the personal health budgets work to integrate NHS personal budgets with social care personal budgets, and there is work now. That work will transfer to the commissioning board to take forward that work, to accelerate that work, and to make it compulsory that everyone with continuing healthcare needs should receive a personal health budget, and all CCGs will have to have in place the systems and processes to be able to offer people a personal health budget, and then there is the opportunity to integrate that with social care. So there is a lot of work in place, but certainly with the personal health budgets, it has been very much a pilot scheme, and we've only just received the final evaluation of that. So, but there is very much an ambition within government and an NHS commissioning board that everyone should be offered a personal health budget if they so wish.
Is there a timescale for that offer of PHP?
For people with continuing healthcare, I think it's by 2014.